Good afternoon. My name is Kelly Curran. I'm the Technical Director for HIV and Infectious Diseases at GBCHealth, which is an affiliate of Johns Hopkins University, and it is my great pleasure to welcome you to the next panel, titled Born HIV-Free, Achieving Zero Mother-to-Child Transmission of HIV by 2015. GBCHealth has been working to prevent the needless deaths of women and their families around the world for the past 40 years, including from preventable causes like HIV and AIDS. I'm very much looking forward to hearing from our panelists on this important topic, and particularly looking forward to hearing from the State Minister of Health of Nigeria, since without Nigeria there will certainly be no elimination of mother-to-child transmission of HIV. Let me just go ahead and introduce the moderator of our panel, who will then introduce the panelists. Ms. Rhonda Zaigaki is the Executive Vice President for Policy and Planning at the Chevron Corporation, a position that she has held since 2011. She is responsible for strategy and planning, policy, government and public affairs, health, environment, and safety. But I think to those of us in this room, she is best known as the energy and the commitment to mother-to-child transmission at Chevron. And so it's a great pleasure to welcome her to introduce the panelists. Thank you.
Thank you. Well, good afternoon, everyone, and welcome to our panel on Born HIV-Free. Quite a vision that all of us on this panel truly believe in. And I hope the panel will give you a greater sense of the progress we're making. We're all very aware of this MDG goal, how important it is, and how there's much work left to be done. But all of us who have joined together in this fight are committed to it, and we're very confident that this goal of an HIV-free generation can truly be achieved. Just briefly, in 2010, from our part, Chevron, we committed $20 million to the UN fight of preventing mother-to-child transmission, supporting 3 countries important to us: Angola, Nigeria, and South Africa. And I'm very pleased to be joined today by leaders in the fight in Nigeria that have doing work with our resources and even more to scale up the services for PMTCT. Let me introduce our esteemed panelists today, who will share their vision, their efforts, and their promising early results. To my immediate left, I'm proud to introduce Minister Mohammed Ali Pate, the architect and leader of Nigeria's PMTCT program. Dr. Pate is Minister of State for the Nigeria Federal Ministry of Health. He also holds the title of Adjunct Professor in Global Health for Duke University. Before being appointed Minister of Health in 2011, Dr. Pate served as Executive Director of Nigeria's National Primary Healthcare Development Agency. He spent 10 years at the World Bank, served on several international expert panels on health, and is a member of the Bill and Melinda Gates Foundation Steering Committee guiding polio eradication efforts. So quite qualified on this topic, I think. Dr. Pate, we'll be interested in your remarks, absolutely. I'd like to go to my very far left on the end and introduce John McGrew, CEO of Apex Partners, a global private equity advisory firm managing over $37 billion. But as an active champion for the eradication of extreme poverty and the development of global health systems, John created and leads the Business Leadership Council for Generation Born HIV-Free, a private sector-led initiative with one goal: to end transmission of HIV from mothers to children by 2015. He's also a director on the board of Millennium Promise, an organization dedicated to ending extreme poverty through integrated community-led development. He's also a founding director of Grameen America. We know them as a microfinance nonprofit that provides loans and other financial services to entrepreneurs living below the poverty line in the United States. Next to Dr. Pate, let me introduce Mark Bisso, President and CEO of Pact. Pact enjoys a growing status as a preferred development partner with national aid agencies, corporations, and foundations. And today, nearly all of Pact's 150 projects in 30 countries blend expertise in governance, markets, and capacity building, impacting healthcare, livelihoods, and national resource management. Before joining Pact, Mark served as Senior Vice President for International Programs at World Learning and also spent 12 years at World Vision, as Vice President for their international programs. And finally, in between John and Mark, we have Ben Plumley, CEO of Pangea Global AIDS Foundation. Ben oversees a diverse set of HIV prevention and treatment programs that target vulnerable populations worldwide, including women, youth, injection drug users, and many others. In 2001, Ben became the founding executive director of the Global Business Coalition. So great history with the organization sponsoring this event. Under his leadership, the principles of workplace and community action were enshrined as the basic foundations of business engagements in the AIDS response and global health. Ben also worked for the private sector, including GlaxoSmithKline and Johnson & Johnson. So as you can see, we have a very diverse and qualified panel on our topic today, and I'm going to start off with a question from Minister Pact. Mr. Pact, we know you're going to be speaking tomorrow at the keynote, so we don't want to steal all your thunder on that, but we're very interested and excited about your Saving 1 Million Lives campaign, and naturally keeping mothers and their babies healthy is a big part of that. Can you talk with us about why you decided to invest your energy so significantly in partnering with the private sector in this area?
Well, thank you. I think the private sector in Nigeria operates at two levels in terms of where we sit. On the one hand, there's a group, the corporate leaders, who have lots of resources of theirs that they may be willing to invest and partner with government and complementary support that they may offer. And then there's the private sector service providers, the operators. Half of the health services in Nigeria are delivered by the private sector, patent medicine stores, but also the health facilities, secondary facilities. 2/3 of them are run by private providers, while 2/3 of the primary healthcare centers are actually publicly owned. So to expand access, we need to look at where the clients actually go, where women go for antenatal care, where do they feel more comfortable to actually go. And doing some analytics, we realized that in fact there's significant scope to expand access by reaching out to the private sector operators. So that's really where this was coming from.
Very good. So speaking of the private sector, one of those partnerships was ended up being with the BLC and John. That's kind of being nurtured and progressing in Nigeria. But no, John, you lead the Business Leadership Coalition for Generation Born HIV-Free. Big vision. You're the lead of the MDG pillar in this area. I'm sure you're all curious. Why would a successful CEO of a financial business, private equity, at the pinnacle of a career, take on prevention of mother-to-child transmission of HIV? And in doing so, what led you to Dr. Pact in Nigeria?
Great. Well, thanks, Rhonda, and thanks for inviting me to be here today. By the way, pinnacle of my career is debatable, so I may be past the pinnacle. But, my quick background is I went to Africa the first time 30 years ago in the early 80s, and like many people here, I know you develop an incredible affinity for the country. And so about maybe 15 or 20 years ago, when I began my philanthropic journey, I became really fascinated with the differences in, in sort of the situation if you're born, like I was, in a place where there's tremendous government support, tremendous education support, in contrast to what you see when you're in Africa. And so that led me to a real focus on extreme poverty. And in short, that took me to global health care, and that ultimately to mother-to-child transmission. I actually think probably what's more interesting is then I went through a very business-oriented approach to where do I want to spend my time in philanthropy? And for me, I look for two things. One, something that's doable, because there's so many great causes that doable in the foreseeable future. So many great causes that are long-term, and for me, I wanted to try to do things that are doable. And secondly, things that have huge, huge leverage on my time and on whatever capital I can provide. And so when I got involved in mother-to-child transmission, you think about doable. This is very doable. It's been proven. Many of you are aware, 1 pill a day. I mean, it's just among the global health challenges. This is one there's already been incredible successes around the world, including in countries in sub-Saharan Africa. But secondly, the leverage on my time and energy is incredible, because there's so many amazing people already working on this. You know, in the private sector, of course, you got Chevron. I see Anu, hello, from J&J, and we've got MacAids, and then in government, you've got PEPFAR, and you've got the Global Fund, and so many incredible implementers. And so the private sector can step in, and I think in a situation like this, play a really catalytic role and try to help coordinate, try to help bring a time frame, a time urgency to a project like mother-to-child transmission that can help be transformative and really change the slope of progress. And I mean, ultimately, the need here for mother-to-child transmission, I think, is very, very clear, and that is the AIDS crisis can't be ended without a generation born HIV-free. And those are very powerful words, generation born HIV-free, and what that means to the success of all of us around the world and in sub-Saharan Africa and other places. So it's been a pleasure to get into this partnership with so much talent and work together hand in hand.
Thank you. I know when we first met, over a year ago, and you explained this vision to me, I remember saying, I'm not quite sure what you're up to, but I like it and we're in. So you remember that conversation?
I do. At that time, I wasn't quite sure what I was up to either, but.
And here we are. Let me turn to Mark, because you're actually working now in one of the states in Nigeria. Tell us a little bit about Pact's expertise and your role in supporting PMTCT, and a little bit about the work you're doing in the Bayelsa state in Nigeria.
Yeah, great. Thanks for the opportunity to be here. Pact is working in the south state of Bayelsa, really at the grassroots level, working to increase demand and uptake for PMCT services, and hopefully to build a system and platform to sustain the provision of those services once they come online. We work with Bayelsa Ministry of Health and community-based organizations and community groups, local government authorities to build both a technical and organizational capacity so they can own the solution themselves and make sure that it's sustainable. We've been doing that since about September and have had some setbacks with the flooding in October and November, with over 90% of Bayelsa state flooded. But nonetheless, we've been able to work in great partnership with the Bayelsa Ministry of Health to train and work with eventually six community-based organizations, train over 28 people in those organizations on state-of-the-art PMCTC service delivery.
Now explain a little bit what state-of-the-art PMTCT service delivery looks like.
Well, one of the things that we're working on doing is empowering and enabling community health education workers to go out and create demand. One of the things that we're very excited about this partnership is that we work really on the demand side. And if we can get a sense that it is possible, that there's awareness that if you can come and get antenatal care and then can get tested and know your status, then that's the first step in fighting this and tackling this challenge. What we like is that there's a real sense that there's a need for integration, that as BLC is doing supply stuff, the hope would be that eventually through this partnership with Chevron, we can connect those dots, the supply and the demand, and to see how that integrated approach is really the key to making this thing all work, that we all play our part in sort of a mosaic of what we can bring to bear. It's take all of us. None of us have all that it takes.
Right, and to your point, everybody on the panel is a different piece of that puzzle.
That's right.
Starting with the leadership at the top, I think, Dr. Pact, so that's good. Ben, let's talk a little bit about Pangea's experience in PMTC and what you see your role in this aspect of the MDGs.
So, and Rhonda, thank you very much for facilitating this session and actually for Chevron's leadership. And at some point, I think it's important to ask the question why Chevron is involved in PMTCT as well, but I'm sure we can come back to that. But in terms of Pangea's interest in PMTCT, it's sort of as John was saying, it is an intervention where you can see an impact quickly. And I like to think of it almost as a sentinel intervention where a lot of things come together. Yes, there's HIV testing. Hopefully it's in the context of prenatal care. We're moving to what's called option B, where the intervention isn't just a set of drugs to help the mum not pass HIV onto her baby, but is a way of allowing her to get initiated into broader care and treatment. And that's really, I think, where the exciting action is going to be. And it's also a statement, I think, of hope that after 30 years or so of this epidemic where, sure, we've had success with antiretroviral therapy, particularly in the north, but interventions that were designed for the south, whether it was the one pill mother-to-child transmission, the nevirapine pill, whether it was some of the microbicide trials or the vaccine trials, we've had a lot of disappointments. And I think what's really important, actually at a fundamental community level, is that something like the elimination of mother-to-child transmission is something we can do. And it then helps us build the cadres, the support that we need to turn HIV on the defensive. Now, what are we doing? Well, Pangea has traditionally been very interested in measuring the impact of our investments. And we think of development of money as investment, not as just development aid. And vis-a-vis the conversations that have been happening with the Global Fund, around what is an acceptable attrition rate of money that may or may not go missing. We are very much of the school that we see these as investments. And so we want to know how the investment that you are all making, how that really is going to, one, impact the rates of mother-to-child transmission in Bayelsa, but critically, what this means around community empowerment. I mean, Mark, you talked about building the demand, building community peer advocates. These are going to be crucial ground troops, frankly, in the broader AIDS response. Minister Partey, you talked about the essential need for collaboration with the private sector. You can't be expected to do all of this on your own. You have a number of priorities. And as you mentioned, Bayelsa has some natural geographic issues that it has to deal with. So we really need your leadership and vision to help us allocate our resources. And then John, from your perspective, the actually delivery of the commodities and the services, these have to be integrated. And so what we're very interested in this program is seeing precisely how those pieces fit together.
Thank you. Thanks, Ben. You made an important point to Dr. Partey that built on your point. You have a reliance on the private sector because of the way your healthcare system is set up now in Nigeria, and you have all these other actors kind of operating in country as well. Describe for me the keys to success in working with the private sector, as a government, as a Ministry of Health, and how you bring all these pieces together in a way that adds the most value.
Well, a couple of points. First, Nigeria is a very large country, 6 million pregnancies a year. So that's the number that we're talking about. And many women do not have access to antenatal care. No woman goes to a primary health care center and says, I want to go into the PMTCT line. She goes because she's pregnant. Mm-hmm. She has some issues. So you need to actually have that integrated package to offer health workers at the front lines, physical infrastructure, training, the test kits, the drugs, the standards, the monitoring, all of that. And that's really the key to deliver not only PMTCT, but also safe motherhood, immunization, and other things. When you look at it, half the health services, at least, that have been delivered in Nigeria are delivered through the private sector channels. So until recently, we've not really looked closely as to how we can collaborate with the private sector. We took one state, and John was very helpful in terms of technical support to work with the state government, not only at the federal level, but at the state level, to really understand, to do a thorough diagnostic, a deep dive at the Nasarawa state to understand the terrain, the physical facilities on the public, but also on the private sector side. And with that, developed an approach where in the last quarter of 2012 until now, we've got almost 20,000 women accessing PMTCT in facilities that have now been put in. 71 facilities have come online as a result of that. Thousands of women have been tested, but also have received ARVs. Now, that is a way that we've now found useful, and it's been replicated in Akwa Ibom, in Benue, and in other states. How we understand the local terrain, each state is different. The constraints on the supply side are different in one state, and the demand side also, the constraints are different. So in that way, by taking state by state, contextualizing our responses, working with the partners on the ground, both private for-profit that are operators, but also non-for-profit private players, with government also joining hands with all of them. to achieve the result that we are achieving. And we're making progress on that.
And would you say that the results, these early results you've seen in Nasarawa State have been more definitive than things in the past? Is this kind of a bit of a breakthrough, or at least the signs of something different?
I think it is. I mean, I really do think that the progress that we've seen in Nasarawa in the last 5-6 months, we have not seen it in the previous, let's say, year and a half or more in Nasarawa. And the process we followed of making thorough diagnostics state by state, I think is bringing in a sense of excitement, gradually building momentum in Akwa Ibom, I know in Benue and many other states. It's focused on results. Traditionally, people focus on inputs, on how many buildings, how much money, how many drugs, how many people have you trained. What we're asking is, are women actually getting ANC? Are they being tested? Where do they get for testing? And that changes the way that you allocate your resources. And the private sector automatically fits in. Because then there are women that go for antenatal care in the private facilities. So how do we get them on board? So in a sense, at least from my own perspective, this is a new way that we're approaching the problem, and we're seeing results, and we do hope to continue in that direction.
And to replicate that.
Yeah.
So a new way. And John, a lot of credit goes to the BLC in the way you've diagnosed this problem. So can you explain to the audience exactly what the BLC model is?
Sure.
In case somebody wants to grab it and go somewhere else.
Yeah. Well, as I said before, first of all, as everybody knows, this is a complex problem with a huge amount of talent around it. And so, to being realistic, we said what the BLC can do is try to be catalytic. Our observation was there is the money there is the will, there's lots of things that are there, but in some countries, why is it stuck? And bringing a private sector mentality to analyzing those very quickly and deciding how to fix them very quickly. When I say quickly, I mean like week by week by week, not month, not year-long plans and those things. And it's interjecting a dose of that. And so the idea, when I first got involved in this and was looking at all the countries and which ones were stuck and which ones were progressing rapidly, I kept hearing, Nigeria's huge, it's complex, it's not making any progress, and, not said quite this way, it's impossible. And so we went about, and really led, by the way, by Anna Levine, our president here, who you should all get to know because she's got the real details of what happened on the ground. But we went about with this idea of let's build a blueprint in Nasarawa State. And the most important thing was Dr. Pate saying this is really important because everybody follows him. When he says this is important, people get in line. And then it was convening and figuring out these plans. We did build an operational plan. But today, having that approach of here's what we're going to do the first week, second week, third week, and we're roughly 6 months into this rollout, and we've had a 400% increase in number of clinics that have been trained, and where there's ARVs available and testing available. We have about a 200% increase in moms on treatment, 20,000 moms now, and this is in one state, by the way, in 6 months, and 1,000 babies incremental that are born HIV-free. And so when you think about that in one state in this short period of time, and the trajectory that this state is not finished, it's, from my perspective, having been in and around global health for a long time, it's a pretty astounding result. And using that blueprint, and I think that's why other commissioners in various states and other community health workers, staff, and training groups are getting on it very quickly, and we're seeing this momentum, this sort of viral move. Now, the key thing we've been able to provide is some talent, really. Some people who come out of a business background, who, in this case, sit in Dr. Pate's office and can be his eyes and ears and energy and to find these day-to-day places that things are stuck and go unstick them.
Thank you, John. So, Mark, Dr. Pate and John talked about some early results on getting women access to care, and the numbers are looking good. As you look, I know you're early in your building community service kind of organizations to help on that side, but can you talk about any early results or signs of promise that you see from your work?
Sure. We did get a little bit of a late start. Working in Bayelsa is real hard. There's a lot of challenges. So some of the results we're seeing weren't necessarily intended to be results. And that's what happens when you come in and work at the grassroots level and try to partner with communities and with local authorities. One of the challenges in getting people to come and get testing, besides awareness, is just the transportation in Bayelsa State. It's a difficult challenge to get to where you need to go. And so our team has worked with the Ministry of Health in Bayelsa to negotiate, in principle, an agreement with the Union of Road and Union of Maritime Transport Workers to provide free transportation for pregnant mothers who want to go and get tested. And so that just is a very simple, straightforward, kind of pedestrian way, pardon the pun, to remove an obstacle of getting tested. But then by the end of June, we'll have over 6,000 folks touched with an outreach of trying to raise awareness, understand why getting antenatal care and treatment is important, how you can do that and be able to make that available. That's all built off of a foundation of trying to, which it's a longer term input of building the capacity of 4 community-based organizations and the Bayelsa Ministry of Health to have the ability to sustain service delivery and to be able to sustain this outreach, to keep that going. Because at the end of the day, year on year, we're hoping to make a 25% increase in the number of pregnant women getting tested. So you have to have that long-term, solid foundation from which to work. It takes a little bit more time. But hopefully at the end of this year and the next 2 years, with Chevron's help and with all these partners here, we'll see that happen.
Yeah, call that front-end loading.
That's right.
You know?
That's right.
Do a lot of work on the front end, better results on the long end. So Ben, there's a theme coming out here about probably a best practice emerging that I'm sure that we're going to try to be scaling up in Nigeria, but probably applicable to other countries and other arenas that have this issue. Pangea is committed to assisting countries evaluating the impacts of interventions and documenting best practices. How do you go about doing that, and how do you see from Pangea's mind, gee, how do I take this idea and inform other people?
Well, in success, you see some common elements, and maybe a lot of it you see up here: national leadership, national leadership, national leadership. And I got to be honest, I mean, notwithstanding, John, what you said about Nigeria, Nigeria is actually a very attractive and appealing country to work in. I say country, it's a federated state. There is a lot of difference. But it is, of course, an established democracy. It has a vibrant economy, not just in the extractives, but with banking and IT. So there's a lot about that is very appealing. There's a lot of investment coming into the country. The harnessing of technical cooperation from academic and other institutional organizations is also a key factor to success. Maybe the one thing that we're missing here, but which is very much a part of the program that Chevron is supporting and funding, is the engagement and leadership of community. And that's one of the areas that I know we're working with Chevron on. I happen to be on the board of a group called the International Treatment Preparedness Coalition. Our chairperson is actually from Lagos, from Nigeria. So as a very good chair, as you can imagine, and as a very strong Nigerian woman, we have a very strong focus in Nigeria. And so there is strong community engagement and support that you can really bring into bear. But one of the things that, more broadly to this, that we're doing, which has funding from the Bill and Melinda Gates Foundation, is to look at best practices over the long term. How do you, we call it retain people in care. We prefer to think of it as sort of keeping people who are HIV engaged in treatment and care over the longer term. And we feel that there are some very interesting early buds from this activity, from this project, that could be very relevant. The very careful planning, which is so key. And then the utilization of the intervention of mother-to-child transmission as an entry point. Look, the one other thing I'd say, Rhonda, and as I've got the floor, I'll raise it, is around the HIV-free generation. And I got to say that bothers me a lot, because I get it from a rhetorical and from an advocacy perspective. But to me, it sort of reinforces precisely the thing we don't want to do, which is just one intervention in isolation. We've got to be prepared for the fact, and I suppose I'm echoing what my colleagues from Levi's said this morning, that we're in this for the long haul. Mm-hmm. And the commitment that you have made, the leadership of Dr. Partey and the leadership of Mark and John are going to be really critical. We're going to be doing this for the next 20, 30 years, and we've got to be be prepared to do that. And we've also got to look at other partners. I mean, John, you had mentioned Johnson & Johnson and their leadership in mother-to-child transmission. We have to connect these pieces together. Not one group can do it all, but are there common elements, and I absolutely believe there are, that we can share and utilize together? And venues like the GBC are perfect for us to share that.
Thanks, Ben. So I think it builds on the opening comment of Dr. Patu, where you said it's not just a mother going into healthcare for one reason. You have to have the whole of the healthcare when she kind of arrives at that clinic, and to make sure it's not just about HIV-free, but everything else with respect to wellness and prosperity in health. So Ben also said it's about leadership, leadership, leadership. So I'm going to give you back the floor again, Minister Potday, and if you had to deliver a set of messages to the private sector who's here today of how they can get involved in saving 1 million lives and doing the good work under your leadership in a country like Nigeria, what advice will you have for them? How do they connect?
Well, thank you. Before I just respond to that, let me say one other thing. I think there's sort of the global market and there's also the local markets. Each state is like a local market. So the constraints in Akwa Ibom are very different. The beliefs, the cultures, the customs are different. A local chief told me about 3-4 weeks ago in Akwa Ibom that if you want to get people out, use drums. I didn't know that. Now, that's very local to Oron in Akwa Ibom State. So understanding that local market is very important in whatever we do, including in preventing mother-to-child transmission. On the Saving 1 Million Lives initiative, I think it's born out of really a desire to make as much progress as we can in terms of improving the health outcomes of our people. When you look at the numbers, where are we losing the most lives? It's mother-to-child transmission, it's maternal health issues, it's immunization, it's diarrheal diseases, childhood pneumonias, it's malnutrition. Not all of those have equally strong champions at the global level, but at the local level, the dynamics, the diseases and all of that tells us what the priorities should be. And a lot of them are preventable. If we prevent those preventable causes of morbidity and mortality, it is in fact possible for Nigeria to save 1 million lives. It's talking about results at the end rather than how much money we need to put in or how many people we need to train at the moment. It's starting back from the answer. We save these lives by expanding access to frontline health services. We've been investing in that now. We need to save those lives by new vaccines. We've been expanding that. Now, for preventing mother-to-child transmission, we need to get the women to the primary healthcare facilities, whether public or private, and have human resources and test kits and track those results. The exciting thing is that we've now measured that, in fact, we're making progress. In 2012, we can account for certain numbers of lives that have been saved. Now, that reinforces the sense that we're making progress and recruits other people that would be key in sustaining that momentum. And so for private sector leaders, and in Nigeria tomorrow, I'm sure we'll hear about the Private Sector Health Alliance, we're fortunate. We have really visionary corporate leaders who are very engaged in this health agenda, even before the Saving 1 Million Lives. So we've now ratcheted it up to identify how they complement what government is trying to do. But there are different aspects of the health value chain where private sector leaders can play their role, and the Private Sector Health Alliance in Nigeria in particular, I think gives us a very good entry point for the global private sector players, for also our own domestic leaders, and working in partnership with government.
So you have a private sector alliance as a convening group to organize all this in the best way possible.
Yes.
That's very logical. Thank you. John, I know your vision is not going to stop at Nigeria. And I know you know that this thing can be solved and we can achieve, no disrespect to Ben, an HIV-free generation. So, what's beyond Nigeria? And what's your message to the private sector, since you have the floor here to get involved?
Well, I think your first statement's a critical one. I mean, to me now, having been involved in this for some time, it is clear that it is solvable, right? There's no longer a question of could it be, might it be. It's this will be solved. So the real question is how fast, right? How fast can we drive it? Because that's a lot of lives and child's lives and mortality that goes along with this. And I'd say the number 1, 2, and 3 thing in that is the will. to solve it, and combined with the local buy-in and leadership. And that's where Dr. Pate has been, so phenomenal, and we feel it every day at the BLC and the people that are in Nigeria on the ground at the BLC, because nothing would be happening if Dr. Pate and the rest of the staff hadn't decided this is really important, and we believe we can do it fast. And it really does take that. I call this kind of thing in business the power of the made-up mind. If you decide you are going to do something, and you don't show up every day and say, well, maybe it'll work, or we'll do our best, or this, that, or the other thing, that drives me crazy. Just decide you're going to do it, and it's doable. And this is clearly doable. And so we needed to start someplace. It's amazing how successful it's been in Nigeria with Dr. Pate's leadership. And so there are many other countries. Like yesterday, we had a meeting with the Permanent Secretary of Health in Mozambique. We need to think about Tanzania, DRC, some other countries that really need some of this catalytic support. Because in those countries, just like in Nigeria, there are a lot of people, super amount of talent in government, in the implementing countries that are there and already working on it. And it really is this idea of how do you accelerate it? How do you pull it all together, and what role can the private sector, not just the BLC, by the way, but lots of people in the private sector can and are doing that by seconding people, by supporting specific initiatives. And I think it's an incredibly promising area that we will solve.
And Mark, you've got a lot of experience in lots of countries. Dr. Pate mentioned that there is differences local, versus national and state, and I'm sure those things move from country to country in your experience. But can you see some applications of what you're learning in Bayelsa that can move to other countries that Pact is working with?
Yeah, absolutely. There's absolutely the methodological and technical learnings that we can translate and apply. But it's sort of at a broader perspective. One of the two things that we have just had reinforced in this engagement in Nigeria and Bayelsa State is and it's been mentioned before, the fundamental galvanizing force that partnerships bring to tackling very difficult challenges, and makes those things that seem unimaginably unsolvable, solvable. In this one, in a sense, Chevron, as a business that's had the power of a made-up mind, I love that turn of phrase, John, decided that they were going to convene. And so besides the money, which is important, this convening nature that private business, either local in Bayelsa or globally as a multinational, can exert is fundamentally what can make things happen, or put in play those things that need to start to arrange themselves to make a difference. But then also what Chevron has brought, I think, and other businesses can bring, is this intentional focus and rigor, saying this is going to get done and we're going to make this happen. But then with the other partners, the leadership, the Saving 1 Million Lives campaign, and the blessing that the government of Nigeria has had on it makes that fundamental framework work. And so you've got to have that. And then you got to look at all the different things, the supply side, the demand side, and then the lessons learned that Pangaea is going to help in this, making sure we're looking at a meta perspective. What's working? What's not working? What do we fail at that we can, in partnership, admit and make better? The second thing I think that we've had reinforced in this particular engagement in Nigeria that holds true in the 30 countries in which Pact works is the fundamental commitment, necessary commitment to local solutions. Yeah. That if you don't start and end with the local communities, the local government, the local businesses discovering and building the solution, even though it takes longer sometimes, it won't last. It'll become input-driven results that will fade over time. And it's nice to see this reinforce that value that Pact has on local solutions, because it means it's true. And we're seeing it in Bayelsa.
Yeah, and you're getting much reinforcement of that from both Ben and Dr. Pate on that point. And so, Ben, I'm going to give you the last question before we open it up for questions. And Dr. Pate made an important point. We're moving from inputs to outputs. Outputs are measurement. We're getting great measurement. But what's the challenge of measuring PMTCT that we need to be thinking of to make sure we're getting reliable information and we know we're on the right track?
Well, at its most simplest, of course, the measurement is a kid born without HIV. But that I'd propose is just use that term, sentinel again, really we want that child to grow up and flourish without HIV. And we also want to make sure that the mum remains healthy and is able, as part of her family, to continue to care for her child and for her other children, and that the family networks are strengthened. So I think one of the things that we all are doing is just looking at what are the actually easy, measurable indicators that we can look at. There will be clearly the health of the kid as the child grows up. But the extent to which the mother is able to remain in care and support is going to be critical. And there are some indicators that we're going to be looking around that. And actually, in many ways, Bayelsa State is a really good place to do that, because the ministry is very conscious of the limitations imposed by the geography. And so there are actually pretty good reporting mechanisms already in place that we can build off. So I think there's a lot here, and it also plays into, I think, a debate that is happening in the international policy circles. On the one hand, you've had this terrifying concept of impact evaluation, which has demanded huge studies to look at whether an intervention works, and it's may well be placebo-controlled. It may require hundreds, if not thousands, of participants, and it will be multi-year. And I've certainly been part of those, and I think that's probably why I have a lot less hair than I did in 2001, and what hair I do have is going grey. On the other hand, you have this methodology that I think is really rooted, John, in the kind of intentional approach that we've seen in the business sector that's called implementation science, which is looking at programs on the ground, seeing what changes we can make as we go. And that means, frankly, we have to take a much more rough and ready look at the data and be prepared to take risks and make changes as we go along. And frankly, that's second nature to those of us who've been in the business community. That's what we do. And for me, that's the really exciting component of monitoring and evaluation of a project like this. So again, taking advantage of the floor, Rhonda, I know you want to open up to questions, but could I take precedent and put a question to you? Because it's something I often get.
Let me check the rules on that.
Huh?
Let me check the rules on that.
Okay. Rules are guidelines, because one of the questions we often get, and remember, this happened at the Washington AIDS conference last year. Chevron had a huge presence, and again, I'm really aware of Levi's quilts here, but Chevron also has quilts, and it's a very powerful impact to see the lives that you've lost in your workforce. But why on earth is an oil company interested in the prevention of mother-to-child transmission? Why on earth are you doing this? And why is it that you've stood out in a way that pretty much no other company has and dumped a whole lot of money into the global fund? What is it about HIV and global health that is making you as a corporation step up to the plate?
Well, thanks for the question, Ben. I'm happy to answer it. We are an oil company, and actually 2013 marks 100 years we've had a business presence in Nigeria. Wow. So that's a long time to get to know a country. And some of our biggest operations around the world, in sub-Saharan Africa, it's where the grip of AIDS is hardest. It doesn't affect the rock thousands of feet below the earth that we drill into and extract for the benefit of energy around the world, but it truly affects the employees that we hire to operate our businesses and manage our businesses and countries. So we feel the brunt of this disease as a business on our workforce, just like the community level, and Dr. Pate feels, in the communities that he stewards and manages on behalf of the government. And when that happens to you, you have to act. And so we acted very assertively, very aggressively, with the goal to eliminate this, first from our workforce. And I'm happy to say that after 8 or 9 years of building quilts like the ones you see in the wall today, the quilt we unveiled last year was a quilt dedicated to all of the HIV-free babies we have born to Chevron families over the last 7 years in Angola and 12 years in Nigeria, with not one reported case amongst our workforce. And so part of it is, thank you. Part of it is, and you know, I mean, John has this extraordinary belief, and for us, it's we've felt this possibility directly, and we know it can be done. And so once you have achieved so much progress with your workforce, it's only naturally when you have a relationship with a country that has been a generation and will be for a generation more, that you invest in their stability, prosperity, as well. And so we reach out into our communities with programs, we connect at the national level, and we are inspired by countries like Nigeria and people like Dr. Pate, where you have that leadership at the top. It makes it very easy for business to engage and make our resources and what we contribute put to good work. And so I think those are the reasons. It's a business issue as much as it is a social issue for us. And if you're in a country long enough, you learn that your business success is truly linked to the stability and vitality of the country and its people where you operate. And it's that basic for us. So with that, I'm going to open it up to questions, and I'm hoping that you can text them in. We have 5 minutes, I think, to do that. And I think if you've learned one thing from this panel, and maybe this panel is unique, is that on this panel, we are all working together. This is a panel where each one of us is an actor on this issue, not separately, but collaboratively. And I think it shows a couple of things, that with strong leadership amongst the governments, people can convene and align around that and make things happen. And secondly, it does take all of us to make it happen. And so there's a lot of reinforcing points today, and I know we look forward to working with each one of you over the years as we work towards this goal, and I know we're going to have success. And on with the question. You've mentioned the exciting transition to option B, and I think it's B+. What challenges do you foresee in implementing this transition, and how much of an investment? Maybe Dr. Pate, and then maybe on to John.
I think a couple of things. One is the financing aspect of it, sustaining the financing, because that's very different. But on the other hand, if you look at it from the perspective of saving lives, and you generate momentum and demonstrate, in fact, that you can deliver, save the baby, but also save the mother over time, then that will begin to fall by the wayside. I think one of the challenges that we've had over time is that lots of investments, but the results were not commensurate with the investment in terms of high proportion of women who are missed in terms of getting tested or having the drugs. And if we change that and we deliver, then that would reinforce this effort. So I think that's sort of really where we are. In terms of the infrastructure, the laboratory infrastructure for CD4 testing, viral load, and all of that, obviously you deal with it state by state. And
yes. Very good. Now, John, the option of B+ was a part of the BLC's kind of early work and reinforcing that policy message with governments. Is there anything you'd like to share with respect to that?
Yeah, we partnered with UNICEF and CHI and worked with closely with McKinsey to try to help create a model to answer this question about cost. And without getting into the details, pretty much no matter how you measure it, B+, in a whole sense, if you look at just the commodity cost or the fact that you're putting a pregnant mom on ARVs for life, you can say that's more expensive. But any other way you realistically measure it, creating orphans, end-of-life care for children born HIV positive. I mean, there's just so many other issues that come in here that make it clear to me and others who have studied this that B+ is in my view, the right way to go. And there shouldn't be an economic concern over any kind of long term. There is a short term sort of front end loading to get the machine going, but I think that's something that the global funding community can deal with. So it's an important decision. I am amazed how rapidly most countries, the vast majority of countries in the last 12 months have switched. And I think there's a lot of reasons behind that, but it was an important transition point in dealing with mother-to-child transmission, because having every country on different programs and the complexity around logistics and all those things just don't make sense. And I think, by the way, on the top of that, B+ to put a pregnant mom on and then take her off and then put her on and take her off, I mean, just doesn't pass any common sense test.
Right.
So.
Thank you. Well, I think we've got us back on time, and please join me in thanking the panel for their vision, their determination, and the results. Thank you.
You do some really impressive work. Really impressive.
Thank you very much.